Oh, I can't, it don't go all the way out.
Is it because you sneeze like Sarah?
Because you sneeze like Sarah.
There's a houseless marsupial. It's a mini possum out there. The zoo brought it.
That's
It
how
was-
cool we're like.
It's
It was
a
just
marsupial.
No.
I'll stick with human.
I want to finish lecture.
No, we're just lecturing.
It'll be there. It's you know,
Okay, here's that, the emphasis on that deep peroneal nerve coming out at that little triangle. Superficial peroneal over here in the lateral foot, and then the lateral and medial plantar right there. What gives rise to these two branches? Tibial nerve. Tibial nerve. The arteries we discussed here coming from medial to posterior tibial. The anterior tibial artery that comes down to supply the anterior compartment. Once it crosses the ankle mortise, it changes its name to dorsalis pedis or pedis. Dorsalis pedis. Here it's called the dorsal artery of the foot, but clinically we know this as dorsalis pedis. So you can feel that on the top of the foot. You can feel the pulse on it on the top of the foot. So those two places, when you're examining for peripheral vascular disease, which you would do in every diabetic. We mentioned the other day, I said, how do you know that would be an arterial clot? You say a cold foot. Well, you feel for the pulses in the foot. There's actually there's a thing called an ankle brachial index, where you do a blood pressure, measure of blood pressure up here, where you feel the pulse at a given systolic pressure, and you repeat that down here in the ankle. That ankle brachial index, or ABI, is important when you're looking at compartment syndrome, or diabetes, peripheral vascular disease, that sort of thing. We'll teach you how to do an ABI later on this year. Across the top of the foot is called the arcuate artery. That communicates with the arches in the plantar surface of the foot. We're not going to worry about these arches. You don't do an Allen's test in the foot like you do in the wrist. So just be aware that once you get into these things, they're going to bleed like crazy. But you can, because of the collateralization, you just tie them off and keep going when you're trying to suture up something in the foot. By the way, here's a tip. Here's a clinical tip. If you have a 2-year-old that has a laceration somewhere, don't say in front of the 2-year-old, we need to suture this up. Because they will go just ballistic. Okay? Tell mom, away from the kid, we're going to need to suture it up. Don't let the kid hear you say that, or you will never be able to hold it down. Okay? Just a little clinical tip. First time I ever did that, and that kid was just ballistic. Spring it, spring it on them. And a lot of times you don't even anesthetize kids because they fight so much. Just suture them. Get after them. If you're going to stick them 6 times with a needle to anesthetize them, and you're going to put 3 sutures in, 6 equals 6. It's the same. So, or if it's a little kid that you want to hurt because they're screaming and they won't hold still.
No.
Yeah. And never, did I tell you, never anesthetize a drunk person. Never use lidocaine on a drunk person. They can pay. They can pay. Scalp wounds, especially drunk people, so they store a staple. Here's the, again, the origin of the the superficial vein. Dorsal of the foot is going to give rise to the great saphenous. the lateral surface of the foot gives rise to the small saphenous. Some clinical correlations here. Shin splints. What are shin splints? So shin splints are little microvascular, micro tears of the origin of tibialis anterior on the tibia bone. Due to excessive exercising without warming up. And they're, the shin splints are painful right here along the margin of the tibia, the point of the tibia here. And they're truly just from not warming up adequately. You can prevent shin splints by just simply warming up appropriately. Once you get shin splints, though, the only treatment for it is to stop exercising and let it heal.
Whenever we would get them in dance, they always made us like wrap our shins like with like compression. Was that ill-advised?
No, it probably would help a little bit, just to give some support. Those ankle, elastic ankle wraps with the heel exposed, or the elastic knee thing with the patella exposed. Those things, or the elbow, those things do provide support. So that would help. But really the biggest thing is warming up. And so if you're trying to warm up the tibialis anterior, then you want to do things like, up against the wall, dorsiflexing, and then, lunges or things like that in order to get the dorsi and plantar flexion going in the foot. A ruptured Achilles tendon, these things are fantastic when they happen, because it's not a little bit, you're going along fine, and all of a sudden your Achilles ruptures, and your soleus and gastroc are a knot up here at the top of your calf. They come in, they always come in, they can't plantar flex, so they can't walk. And the test for that is simply you have them lie prone with their foot off the end of the table there, and have them press against plantar flex against resistance against your hand, and you want to do it on both sides. Okay. Rupture of the plantaris tendon, again, they come in hobbling like that, but there is no decrease in strength on plantar flexion versus an Achilles rupture. This is a disorder of teenage boys mostly. It's called Osgood-Schlatters disease. You see this a lot. And what it is there's a growth plate here at the tibial tuberosity. And that growth plate closes in late teens, but in boys that are very active in football and running sports here, the tibial tuberosity will actually separate from the epiphyseal plate and can fragment. And what it produces is a lot of tenderness every time they extend their knee. Every time they extend their knee, because that's how the quadriceps are working, right? It's an inflammatory process right here. You don't cast it, you don't need to send them to an orthopedic surgeon, but you do have to require rest until this goes over, until it heals itself. So Osgood-Schlatters, and it's usually a chronic disease. It will take them out of football for the rest of their career. It's just, or whatever the activity is. So, and it will stay that way until that growth plate closes. Varicose veins, we talked yesterday about incompetent valves produce varicosities down here. The difference between, you get varicosities of the superficial veins. You do not get varicosities of the deep veins. And one of the reasons is the deep veins have all those muscles around them that are contracting all the time as you're walking, and that helps move blood north. In the superficial veins, the same process is going on. However, you have the muscles on one side and the skin on the other. So you don't have as much of a squishing action to propel blood north. We talked about phlebitis and thrombophlebitis. Very painful condition. Steroids, antibiotics. You can see here, there's the, what vein is that? That's the great saphenous vein. The other person's got thrombophlebitis in the entire great saphenous vein. Here's a deep vein thrombosis right here. One of the telltale signs of a deep vein thrombosis. So let's say suddenly you occlude one of the deep veins of your leg. Could be the posterior tibial, could be the peroneal, whatever. Could be all the way up to the popliteal. In addition to swelling, which is obviously a sign, what type of swelling, why do you have swelling there? You have swelling because you have a decreased venous return, right? So what you want to do is, if a person that you suspect has a DVT, you want to get out a tape measure and measure, pick a point. So there's the inferior patella. I usually go 5 centimeters below the inferior patella, and I'll make a pencil mark, a pin mark on the skin, and do it on the other leg, and then you measure at the same place. So you want the two calves to be the same diameter, or circumference, not diameter, circumference. If they're not, then that helps you suspect DVT. How about the pulses? Excuse me, the pulses in here. Do you think anything's going to happen with the pulses? No. The pulses are on the arterial side. They're going to be just fine. With an arterial occlusion, you don't have swelling.
Cold feet.
You have cold feet and diminished pulses. Paul?
So you said with the superficial thrombo, whatever that word is, that you wouldn't do much for that?
Oh, no, yeah, you treat it, but you treat it with steroids, you treat it with antibiotics, you treat it with pain relievers.
You're just treating the pains.
Huh?
You're just treating the symptoms?
Yeah, you're treating the symptoms. Well, you're treating the inflammation with the steroids,
Mm-hmm.
but you're not treating the blood clot. That you don't have to treat.
Okay.
In time, the blood clot will dissolve, usually, most of the time. When we get into coagulation, we're going to go through the clotting mechanism and what happens when clots break down, the process for breaking them down. What you would, the lab test here you would order is called a D-dimer, a little d hyphen dimer, D-I-M-E-R. And that is a protein it's a split product from degradation of fibrin. Fibrin forms a clot. So you're measuring this split product from the dissolving clot. So that's how you would, so one of the things, if you saw that right there, you would get a D-dimer. Is it phlebitis or is it thrombophlebitis? The either one is going to be painful. The thrombophlebitis, hopefully you can feel the clot, but if you can't, the way you get a D-dimer. That'll tell you right there. If the D-dimer is negative, then it's just phlebitis. Yes, ma'am.
Do you know how to differentiate between that and a DVT?
No, it won't differentiate. She said, does the D-dimer differentiate between a superficial vein thrombosis and a deep vein? No, it's just looking at blood clot. But you can use it all the time. If you're looking at like a pulmonary embolism blood clot, that's one of the tests to rule in or out a suspected PE. Pitting edema down here is, I think we've talked about that before. You take your thumb and you just press in the skin. This is moving fluid in the extravascular space. So there's a difference here between lymphedema and pitting edema. Lymphedema is, it doesn't pit. Fluid does. So this would be like a person with congestive heart failure and a bad case of fungal nails on the boot. But lymphedema doesn't pit. That's a big thing. Lymphedema doesn't pit. Fluid does. And you measure pitting edema by how deep that pit goes and how high it goes. If you have pitting edema down in the ankles, that's one thing. If you have, on your note, if you have pitting edema, like 3+ pitting edema in the proximal tibia, that means you've got fluid all the way up to here. So you describe pitting edema in the context of grade 1, 2, 3, 4, and how high it goes. Is it mid tibia, proximal tibia, ankle, and so on. You're not going to find it above the knee because it's just, your thigh is just too fat. You have fat thighs. Okay? Here's a compartment syndrome. We talked about this several times. The treatment for it is you just open up the compartment. And you see this is a particular type of closure material. Basically, it's like a shoelace. As the swelling goes down, you just keep tightening and tightening this up until you eventually close it. But you don't go in there and close this. This is opened in the OR, and it's left open until the, yes ma'am?
What about infection?
Does it increase the opportunity for infection? Probably everything does. But I mean, this is managed by, you know, you cover this. You don't leave it open to air. But these things can happen with, I've seen them with snake bites on the hand. You know, in rural Oklahoma, the swelling gets so big in here that you have to do a fasciotomy to open it up. I've seen it, trauma, mechanical trauma. It doesn't just happen. Something has to cause it to happen. Yes, ma'am?
Does it affect the muscle in any way? I know some athletes that had to have it done because they couldn't run or do anything. Does it affect the way the muscles work, or if they can build the muscle back?
Not usually. Not usually. Not usually. You know, these things take weeks to months to heal. So. Here's some toe problems. You know, when you get older, the big toe will often, if this stick is the big toe will often move laterally, like that, at the MP joint. That's called hallus valgus. By the way, valgus, if you look here, valgus is when your foot, your knees go inward and the distal part goes outward. So valgus is like that. Okay? Varus is when they go in. I'll show you, there's a slide on here in a minute. So this is hallus valgus, and then it's going out. The big toe is pointed out. And some people, the big toe can actually cross over the other toes. The point where it sticks out there is known as a bunion. That's a bunion. And the way you fix this, the way the podiatrists fix it, is they go in and open up and they shave off those parts of the bone and realign the toe straight. You know somebody that's had that done? A lot of people. You've had it done? Really? Both sides or just one?
Just one. I need the other side done, but the surgery didn't go
Wow.
well.
If you don't want to sit next to the freaky thing over there, move up to. So anyway, you're awfully young for this to happen.
It runs in my family.
Oh, really?
Yeah.
You see it usually after the age of probably 50 is where it's more common.
What causes it to do that? You said it's common. What causes the toe to that?
I don't know. You know, it's attributed to wearing tight, closed-toed shoes.
Mm-hmm.
But you know, that was the common thought back in the 60s, 70s. But now women don't, and it's mostly women. Mostly women. Any males in your family have it? Yeah, it's mostly women.
I was gonna say, I've seen it a lot with like the increase in like the Q angle of the hip to the knee.
Right.
Is relative to it, so that's why it runs in families, and then a weakness of the inverters of the foot. Just over time, they kind of, you have this counter rotation, and so that first toe will start negating.
Cool. Well, that is the reason then.
Yeah.
Okay. The thing about the shoe, though, is not relevant because now women don't wear such tight-fitting shoes that scrunch their toes like they did back in the early days. I'm glad to see that there's a mechanical reason for it. So, I guess if you bisected your pelvis and rotated your feet, we wouldn't get it anymore. But that's pretty drastic to avoid. Now up here are corns, and corns are basically just calluses on the dorsal surface of the toes. You know, shaving them down is the treatment for those. This is a fracture of the shaft of the fifth metatarsal here. Pretty aggressive fracture. That's going to go to the OR, no doubt. The fracture of the metathesis of the fifth metatarsal, remember I said it was a Jones fracture. This is not a Jones fracture. The Jones fracture is down at the metathesis only. You would describe this as a linear, complete, displaced fracture of the fifth metatarsal, the diathesis of the fifth metatarsal. And I'm not exactly sure why I have this slide in here, other than to show you, right here at the base of the first metatarsal, actually the head of the first metatarsal, you see those two round white spots? Those are right there. Those are seismoid bones, and you have them, everybody has them there. They're in the tendon of the flexor hallucis longus, and they're like the patella. It's a seismoid bone. You also have them in your thumb. I don't think I mentioned that when we did the hand. But when you see those two little dots right there, don't get alarmed at what, oh, there's a mass. Oh, those are just seismoid bones. They can be displaced, as it says up here. You can have displacement of those little boogers. This is knock-kneed and bow-leggedness, or valgus and varus. This word right here, vargus, I've never heard of that word, so I put varus at the top. When you're in the OR assisting a surgeon and you've got the lower extremity in your hands, and they say, well, more valgus or more varus, you're going to move the knee, or particularly the knee or the ankle, inward or outward, as is described here. This is, well, there you go. Did I skip one? I did? Oh, there it is. Is that the one that's good?
Yeah.
Okay. Different types of deformities here. A hammer toe is an interesting thing. It's like the extensor tendon is pulling it up. So it looks like that. Some people have all their toes. Do you have them?
That was the surgery I had. So I only have
that's
my
right.
MP joints. I don't have my DIP.
Oh, okay. Does it look kind of weird if you took
Like,
your
I
shoe off?
only have it on one foot. So one foot is like the claw and one foot is like this. So I
Wow.
only can do this on one foot.
So let's hold her down and look at her feet. When we
Hey,
get
you
on the
can
left.
see them. I don't care.
Well, let's see them. Let's see those freaky feet.
Do I go
Yeah.
down?
Yeah, come on down here. Now get your cameras out again. I want to see some people taking pictures. I was up there on all these iPhones. Huh?
Keely, get on the deck.
Get on the desk.
I like that's the only one that's like, let me see it.
Yep, we got this.
Okay, now you gotta roll.
So the, like you said, scars in the joints.
Lay on
Yeah,
your
yeah.
back. Lay on your back. Put your feet down.
So this one I can grab things, and this one just goes like that.
Oh,
Wow.
That one.
And then I opened up the tendons down here.
Oh, yeah, you can see that. Yeah, you can see where.
Did it bother you? Is that why you got surgery?
I played soccer, so when I'm wearing my cleats, my toes were like that, so my toenails kept flipping up.
Oh, okay.
Oh.
Did they do the tattoo at the same time?
Yeah, well, that's these drawings. Oh my god, yeah, because they put pins in all the toes.
I had the same surgery and it's just the most horrifying thing.
It like turns my stomach, and I can't like walk in sand because I can't grip
So
the
you
sand.
still have the pins?
They dissolved.
Oh, really?
wedge out
Don't
of the
do
bone.
it.
They should have, I don't know. Maybe put it
You
in.
know, Rob Orwell, my first
I
boss,
just like,
his toes are the claw toes, like his big toe is bad, it's like
Who is this?
Brock.
Oh, yeah, Brock.
Yeah, have you seen this name?
Yeah. Well, listen, you should be able to, if we took you and put you up next to a tree, you should be able to hold on to the tree. Okay, so, here, the arch support, the head of the talus is fallen, so you're gonna have flat feet there. Again, there's your normal footprint, exactly as I've drawn on the board. Here's what flat feet look like. When you do the footprint of somebody with a flat foot, it's like that.
Is that like what you consider a fallen arch?
Yes, yeah. Okay.
Oh, I see.
Well, this is there are a whole different variety of clubbing of the feet. These are congenital conditions here. You can see these extreme inversion of the foot. Most of these will resolve on their own. You don't have to do a whole lot with them. Sometimes people, it used to be very common, but now it's much less so. We'll brace these to try to get them to straighten back up. But usually it's a condition of you being crammed into a uterus for 9 months, and then, so that's why they eventually will straighten out. You had it.
are there any fixes for, I was thinking for that slide earlier, the bow-legged and knock-kneed, I guess depending on when it's, because I've seen even little kids where it's very obvious. Are
Yeah.
there braces or anything to change the development?
There used to be a lot of bracing of kids of the lower extremities, but now you just don't see it. Now I think people realize if you just leave them alone, it'll eventually fix itself. You know, you go to the mall, when I was growing up, you'd see Forrest Gump everywhere. They had braces, but now you just don't see it. Onychomycosis is a fungal infection of the nails that produce thickened, yellowish, flaky nails. People are more prone to this genetically than others. Unfortunately, when you get rid of it, if you get rid of it with medication, it'll usually come back. Lamisil pills are the pills to take. You have to take them for 3 months, but then most of the time it'll come back. So because Lamisil has a side effect of liver damage, I usually try to talk people out of it. You know, just live with it. So, doesn't have to involve all nails, like on this guy right here, or a woman, but they can be really impressive. When they get ingrown, I can tell you this: when they get ingrown and you're trying to remove a fungal nail, the fungus is beneath the nail plate, right? It involves the whole nail. So it's down there next to the bed. So the nail doesn't separate from the bed as easily as it does a normal nail. So that's one thing you're going to find. The second thing you're going to find is when you take your hemostat and you grab the nail to pull it off, the nail will usually just shatter, you know, or mush. It mushes. It doesn't shatter like glass. It mushes like you're squeezing a brownie or something. Go ahead.
I was going to say our cadaver has a pretty impressive one if anyone is interested.
Yeah. You know, I'll show you how to take the nail off down there today. If you want me to show you how to do a nail incision. We can anesthetize them as well. Yeah. This is a thing. So if you remember this, you're going to look like a rock star to some preceptor, because you're going to encounter this clinically. Some people, they say, you know, right at the front of my foot, every time I walk, I just get this stabbing pain between my toes. It's usually the second, third, or fourth toes. It's just a stabbing pain. Every time I walk, there's nothing on my foot. If you look at the foot, there is nothing there. You feel the foot, there's nothing to feel. There's a thing called a Morton's neuroma. If you here's the nerve, the plantar nerves, these things can form a neuroma. It's not like a ganglion cyst up here. It's an actual tumor, benign tumor of the nerve sheath. You can find them on ultrasound. You send them for an ultrasound if you're suspicious. But the only way to get rid of a Morton's neuroma is to excise it. And you see it, they open up the space here, you send them to a podiatrist, and they they cut the neuroma out. Of course, they're going to be anesthetic on the toes, but nobody's going to know that. So, Morton's neuroma. So if you remember Morton's neuroma, put that on your differential, and that'll make it, wow, you know something. Here's plantar fasciitis. So the difference, one of the things about plantar fasciitis is when you go to sleep and you've got your foot in bed, there's no weight on the foot to keep the plantar fascia stretched. So during the night, it tightens up. So in the morning, the telltale sign of plantar fasciitis is when you put your foot down, it's painful. Well, the way you fix that is you have them stretch out their foot in the morning, and that helps a little bit. There are also devices you can wear overnight to keep the plantar fascia stretched out. I've never recommended these to anybody. I don't know how you can sleep with that on. So I tell people to just start with, in the morning when you get out of bed, stretch your plantar fascia, and that usually helps. There's a fix for it. You can inject this with steroids to decrease the inflammation, and in extreme cases, the orthopods can go in there and remove the plantar fascia. But usually, injections are the worst thing you have to do. Most of it can be dealt with just by stretching it out. That's another thing. When you have a complaint like this, note the timing. The timing is important. If you're dealing with osteoarthritis of the ankle, that's a problem that, or rheumatoid arthritis even, that's a problem that's going to get worse as the day progresses, as you're using it. But things like plantar fasciitis gets better throughout the day. So when you have a person coming in with an illness, always remember to ask about timing. Like headaches, for example, headaches. People do not go to bed or wake up with headaches unless there's something really wrong. Now, going to bed with a headache, you would think of the differential with a migraine. I mean, that's one of the treatments for migraine is sleep. But you don't usually wake up with a migraine. A tension headache, like you get from studying, you don't wake up with that. You develop it during the day from overuse of your neck muscles and frontalis and all that kind of stuff that we've talked about before. So timing is an important thing to note in medicine. Heel spurs are, when you use a tendon excessively, it usually calcifies, and you'll wind up with there's a little heel spur right there going up into the Achilles tendon. Here's a heel spur right there going into the plantar fascia, plantar muscles. When you Google images, heel spur, these people come up. So I assume that would be the name of the family, the heel spur family. I don't know if they still come up. If you do a Google images, do they still come up? They look like a happy bunch. Do they come up? They're not coming up on your engine? Okay. So the question, if I put this on a test, the question would be like, what body of water is that? Something like that. So. Not what family, because that would be a first layer type of question. This would be more of a thinking question. A man, a woman, and their 4 kids went to the ocean.
Which one?
Yeah, which one? Warts, The common name of wart is verruca. Verruca,
Like Varicose salt.
Like that.
Verruca, V-E-R-R-U-C-A, or V-U-R-R-U-C-A, Verruca. The common wart, the word for common is vulgaris. So common acne is acne vulgaris. Common warts are Verruca vulgaris, and so on. You may see these warts that are unique to the plantar surface of the foot. They're called plantar warts or seed warts. They look like little seeds. They are hard to get rid of. You know, a wart on your hand, you can freeze it a couple of times and you're done. These guys, they don't, you have to essentially cut them out. And they are painful to walk on because they develop a lot of time on surfaces. You've had a lot of people, they're very common.
They injected mine with like a yeast substance
Yeah,
so that my body would attack I had them really, really bad.
Yeah.
And they would attack the actual wart, and they went away after that. But that injection was so painful on the bottom of my foot.
that is a way to treat certain warts. They'll inject them to initiate an immune reaction. This is a virus. Warts are viruses, if you didn't know that. You know, most of the time, like the warts on your hand, like little kids, you eventually build a defense and they'll go away. By the time you're a teenager or 20 years old, start dating, they're usually gone. These guys develop more into adulthood, teenagers and adulthood. You see them a lot in high school athletes. They're very painful to walk on. A friend of mine, his dad was a neurosurgeon. When he was a little boy, he said, "Dad, I've got this thing on my foot. It hurts." So he looked at it, and his dad was such a weird man. He took his pocket knife out of his pocket. Now, he was a neurosurgeon, right? So he threw Bill down on the floor and grabbed his foot like that and took that pocket knife and carved that wart out of his foot. No anesthesia, right there in the vestibule inside the front door. I mean, it's clearly child abuse, but got rid of his plantar wart. So there you go. Gout is the old term for gout is podagra. This is a disease of purine metabolism. You know, purines, pyrimidines. So you can't get rid of these things, and they crystallize out in joints. Their uric acid is the crystal, and the most commonly affected joint is the MP joint of the great toe. Probably 90% of all cases of gout involve the MP joint of the great toe. If anybody comes in with a joint that looks like that, it's hot, it's swollen, it's exceedingly painful. You can't let the wind blow over it. You can't let the sheet touch it. It's that painful. It's very painful. That's gout. And it responds very quickly to non-steroidal anti-inflammatories, a little stronger than Motrin. But you don't need to use narcotics. And that takes care of the inflammation, and the problem goes away in a day or so. If you don't treat it, though, over time, it'll cause destruction of the joint. But you never see that anymore these days. You can see right there how that joint was sort of blown up there. This used to be called, back in the days, back in the Renaissance, the disease of kings, because royalty ate meat regularly. So this is a purine issue. You're going to find purines in meat, not grains, and so it was mostly a royalty thing. We'll talk more about gout when we get to the musculoskeletal system, but know it for here, okay? This is a Jones fracture. This is the little fracture I was telling you about before. Usually you're going to have to go in and put a huge screw in that little bitty fracture. And that's usually the only way to get them to resolve.
You skipped it.
What's that?
You skipped it.
Ingrown toenail is, these things are great. This is the lateral part. So you don't have to take off the whole nail, you can just take off a wedge, the ingrown part. If you'll notice, his nails are trimmed down like that. That is how you're going to get an ingrown toenail. What you do, if you look at toenail clippers, there's a difference between toenail clippers and fingernail clippers. Fingernail clippers that you get at the store, the bite looks like that. So when you clip your nails, they're rounded like that. Toenail clippers, it's actually like that. So what you want is the toenail, you actually want the toenail to look like that. You want these two edges to grow beyond the edge of the nail bed, nail plate. You want it to be like that, not ingrowing into it like that. Okay? Jones fracture. This is called a Liz Frank fracture. It's a fracture of the mid. It's a generalized fracture of the midfoot. Usually involved with some heavy object landing on the midfoot, or a car running over a foot, or it's usually not from falling from a height, landing on the feet. That's going to usually break your fib, that area. This is a force from above usually, and you can see where this whole second metatarsal here is just all blown up. These things are orthopedic nightmares, and they're going to produce a lot of arthritis regardless of how they heal later on.
Is it from dropping something on your foot, or how do they usually occur?
Yes. Did I say that?
Yeah.
Oh, sorry.
Okay. Yeah, I'm sorry. I don't know.
I heard not
So when you
landing.
say something like that, I said, did I just say that in my head, or did I? So, okay, so yeah, don't assume that you're wrong, you're right and I'm wrong, or vice versa. Who knows? This is a traumatic fracture called a trimalleolar fracture. So we know about the medial malleolus and the lateral malleolus. There's artificially in the back of the tibia here an area that sort of sticks out that orthopedists will call the posterior malleolus. Anatomically, it doesn't exist. But if you fracture through that as well as the medial and lateral malleoli, it's called a trimalleolar fracture. And it is certainly an unstable mortise. It is going to require a lot of surgery and a lot of non-weight bearing for a long, long, long time. And I think that's the end of the content for this concentration. Victoria, if you'll just grab onto one of these guys, they're headed over to the lab, and we'll